have important deficits in psychomotor functioning for up to 3 weeks. So psychomotor functioning, what's that? The two main things that they assessed and found were deficits in critical tracking, so the ability to maintain a straight line, and then deficits in divided attention, which is the ability to pay attention to stoplight, pedestrian, rear view mirror, and your gauges, kind of all at the same time. Sometimes people who are using marijuana can become hyper-focused on one of those things and lose the ability to pay attention to all of those things in context. And so I think this is very important here, because the argument has been around driving has been we need this 5 nanogram per milliliter of whole blood limit inference of THC as our limit, because I use marijuana every day, and I would be above that level for a week even if I hadn't used. And so I think the argument is, A, there's not good science to support that comment, but B, even if somebody's not using acutely, there's still the subacute impairment that people can have. So I think we need to pay attention to that as well. All right, so these are more data on this. If somebody has a whole blood THC level of 1 nanogram per milliliter, they're over 3 times more likely to be involved in a fatal crash. We as a state have drawn 5 nanograms per milliliter of whole blood as our possible inference. Again, that's a possible inference, not a per se level like 0.08. And so if somebody has that kind of level, they're about 5 times more likely to be involved in a fatal crash. So I think the driving thing is very tricky. The current standard is the drug recognition expert evaluation, which studies have shown many adults with tolerance to marijuana can pass pretty easily. And then in terms of doing phlebotomy and trying to assess intoxication with marijuana can be very tricky that way. And by the way, that's a mess too. In Denver, the Healthy Kids Colorado survey showed that 25% of high school students in the last month got into a car driven by somebody who had just been using marijuana. So low-hanging fruit, we need to get the message out there that it is not safe to drive under the influence of marijuana. There's a myth out there, I drive safer under the influence of marijuana, I drive slower. That's a myth, and hopefully that's low-hanging fruit. We really need to get that information out there. And then I think I'll just do this last slide, and we'll have more time for question and answer here. So in the hour after using marijuana, adults have a 4-fold increased risk of having MI as myocardial infarction or heart attack. And so marijuana causes increased stress for the heart because, again, there's carbon monoxide. Remember I showed you that slide? It increases pulse, and so the heart has to work harder. Cannabis dependence doubles one's risk of having bronchitis, wheezing, chronic cough, so it makes sense. All that smoke in the lungs has an effect. It may increase risk of head, neck, lung, testicular cancer. It's not as clear-cut as tobacco smoking, but there are at least preliminary data showing that this may be the case, and we'll need to continue to study the associations between marijuana use and risk for various different cancers. With respect to testicular cancer, that's interesting. There are those CB1 and CB2 receptors in the testes, so there's at least a possible mechanism for that. So stay tuned. We need more research on that. Maybe invite me back in next year or something, and we'll have those data. And with that, yeah, so I guess we'll finish up and have our time for a question and answer.
Hello, everyone. This is our last Q&A session before lunch. There are still helpful people in the aisles if you want to pass your note cards out to them. Just a couple notes on the agenda. As you know, this morning Dr. Thurstone's been speaking about the effects of marijuana use on the adolescent brain. Directly after lunch, he'll be speaking about marijuana and the law in Colorado, and I can say from listening to his presentation on that topic in Denver last fall, it was much more engaging than I anticipated. So I really hope that you're able to stick around for that. There's a lot of good information and perspective on prevention that Dr. Thurstone has. After that, we'll have a panel this afternoon. There are 10 people who've generously agreed to sit up on the stage and share their local perspective with us from across our region. And we have some structured networking to promote conversation amongst all of you at the end of the afternoon. So right now we have about 15 minutes for Q&A. I've got quite a pile here. I see more of them coming down my way, and we will just make as much progress as we can. The first question, Dr. Thurstone, what is the comparison between the amount of time it takes to become addicted to marijuana versus the time it takes to quit or recover?
Wow, that's a great question. Okay, so for the first, I'll take a stab at it. For the first one, actually, I think we do have some data on that. Dr. Crowley, who was the director of the Division of Substance Dependence at the University of Colorado, now he's retired, actually studied the time from first use until cannabis use disorder among youth in substance treatment. And he actually compared alcohol, tobacco, and marijuana. And so time from first use to development of cannabis use disorder for marijuana was about a year for tobacco, and 2 years for alcohol. So tobacco and alcohol, or tobacco and marijuana, about a year, they were the same, and it was shorter time to developing dependence than alcohol, which was 2 years. So I think that kind of at least answers that. In terms of the whole recovery process, I'm not sure I have great data on that. What we know is that 2/3 of adolescents in substance treatment relapse within about 6 months following treatment, so relapse rates are really high. And you know, the conventional wisdom around addiction, at least in the 12-step community, would be that it's a lifelong recovery process. And so if somebody stops using, their substance use kind of progresses in the background, and if they start using again, they'll be at this level again. Hopefully that makes sense. But so I think the conventional wisdom is, you know, it's really a lifelong process.
So I can't help myself. I need to give a shout out to the youth who are in the audience. You may have noticed that there are some high school, middle school youth and recent high school graduates in our audience, and I just want to appreciate you all for being here. And I can't help myself, but that last question that Dr. Thurstone just answered, his initial response was, wow, that's a great question. That question came from one of the youth in our audience, so I just needed to say that.
Yeah.
Next question. Is there any other ethical way to test the effects of marijuana on the brain and body of humans without bringing animals into it?
Right. Yes. Let me think about this here. So the best we can do is about what we've done with the Dunedin study, where we follow people longitudinally, and then they choose to expose themselves or not, and then we try to match, you know, by gender, age, and similarities, and follow people like that. So I think the short answer is no. The one question we still have to get at, though, and this was how it's a little bit similar with tobacco. How do you prove that tobacco causes cancer? Well, you have all these studies like similar to what I've shown, but you also follow tobacco use rates, prevalence over time, and correlate that with cancer rates over time. So we've seen a nice drop in smoking prevalence, at the same time, we see a nice drop in lung cancer prevalence. Does that make sense? And so that's another way to try to get at causation, to try to get at that. And so one of the things that a hot area right now is to track marijuana prevalence and prevalence of psychosis, schizophrenia in the community. And some initial findings so far, at least that I've seen, finding a parallel, that those two lines are parallel. But we need more data on that. So that might be one area of research that way.
Next question. How does testing with marijuana differ throughout the world? And is this research mostly condensed to the United States?
Right. So how does testing differ across the world? I'm not sure testing like the urine drug screen testing, or I'm not sure that differs. I do think in terms of the research done around the world is an interesting question. I'll take a stab at it. The National Institutes of Health funds the majority of medical research in the world. And so that's why a lot of the research findings I show you are here in the United States, just because we have that funding mechanism for that. The information about the gateway hypothesis, that's something that's been studied really cross-culturally and shown to be the case. A lot of the studies, like for example, the study on psychosis came from Sweden, where they have very nice, they have a very nice way to track their patients. They have basically socialized medicine, and so they can track people very easily that way. It lends itself very easily. New Zealand, similarly, a lot of nice longitudinal studies, because it's just, you can do that in New Zealand. They again have a way for tracking people's medical outcomes, and people don't move as much. And so a lot of those kinds of studies, the longitudinal studies, are going to be coming from outside the United States. I think there's one other point to make here, in that one of the arguments has been we need to legalize marijuana in order to study its effects and its therapeutic effects and any kind of effects. And I think, as you can see, a lot of research has been done, and we could go on and on and on all day in terms of the research, despite it being a Schedule I substance. There's still a process for doing research with marijuana without necessarily legalizing it. Just to comment on that.
Next question. What tools are available to help aid marijuana cessation, and are there THC replacement therapies?
Oh, right. Awesome. Thank you for that question. So let's end on some good news. Who's ready for good news, right? So there are effective treatments for marijuana addiction and addiction in general. And so this is the treatment that we're going with here in Denver, and our application to be on the National Registry of Evidence-Based Practices is pending, and we have a school-based version that we're moving forward with on this in Denver Public Schools. So come talk to me if anybody's interested in this. But I mean, the most studied treatments here, cognitive behavioral therapy, helping people change the way they think and act. Old school thinking, you got to confront people, right? Get them to admit they're an addict. New school thinking is to use empathy, motivational interviewing, really find out what motivates people. We do integrated mental health substance treatment, so treating co-occurring problems, not just the substance use, but the whole person, really. Case management, helping youth get involved in pro-social activities like Boys and Girls Club and other things that are healthy. And then incentives. We reward youth for clean urine drug screens, basically, is how it works, and getting involved in pro-social activities. And so I think the bottom line to answer the question is the backbone of treatment is a behavioral treatment and a life change, and that will always be the backbone of treatment. I doubt we're ever going to have a magic pill for this. And so are there substitution therapies? The short answer is no. Some of those studies have been they've been studied. So there's a pill that's available through pharmacies that is THC or synthetic THC, and has not in general been shown to be helpful for marijuana cessation. There's one medicine we have now that I have some confidence in. It's called N-acetylcysteine, or NAC, and you buy it at like a vitamin store, basically. It's a vitamin and an antioxidant, and it decreases relapse, cue-related cravings, stress-related cravings that lead to relapse. And so that's one exciting development that can be a helpful adjunct to treatment, but not to replace the behavior, the hard work, basically, that comes with treatment here.
So these next two questions are similar. I'm going to read them together and let you choose how to respond. It seems like everyone smokes pot to quote-unquote cure a variety of diseases and physical ailments. Is THC really a good option to treat all of these different conditions? And recently, a doctor in Denver prescribed medical marijuana with no THC. The pain is relieved without a high. How does this type of marijuana affect the brain? Are you familiar with any research on this?
Yeah. Okay, so there are over 60 cannabinoids in marijuana. And what's a cannabinoid? It's a 21 carbon containing molecule, of which tetrahydrocannabinol, or THC, is one. Another one that's been studied is cannabidiol, or CBD. And I didn't include the possible therapeutic effects of marijuana in this. It didn't fit the subject I was given, adolescent development. But there are some small studies to suggest we need further research into, for example, the effect of CBD on seizures, or the effect of CBD on anxieties. I'm very interested in the possible effect of CBD on addiction. So we absolutely need to study these things. I think that we need to do this in a responsible way, though. So there's a process for studying medicines and interventions. So first you develop a pharmaceutical grade product that you know is pure, you know how to dose it, you know exactly what's in it, and you can say, here, take this, 0.5 milligrams twice daily, something like that. And so we need to go about that process. And my concern is that the CBD oils, which don't have THC, are not that pharmaceutical grade. There's not that level of quality control. So how to get that kind of quality control? We should push for compassionate use of marijuana-based medicines before final FDA approval. And there is actually a mechanism for doing that. The pharmaceutical company is GW Pharmaceuticals, which is making a pharmaceutical grade CBD, which will be an oil, a pharmaceutical grade THC/CBD, which is an oral mouth spray. And with the proper paperwork done by the patient and the physician, these products are available 3 months for free through GW Pharmaceuticals, going that route. And so that to me is a safer. First rule of medicine is do no harm. Yes, thank you. And I think that's the safest way to do no harm around that.
All right, I've got 2 more questions before we wrap up and head to lunch. They're different questions. The first one, do you believe a 5 mg per milliliter is sufficient for a per se level? Higher or lower, what would you recommend?
Right. So this driving thing is a mess, I think, and I do not envy our law enforcement colleagues here, and I would like to have their opinion on this as well. So, as I mentioned, the DRE, drug recognition expert evaluation, is very difficult in chronic users who have developed tolerance and can pass some of these tests. The 5 nanogram per milliliter of whole blood, to me, is too high. I mean, what did I show? It's a 5-fold increased risk of being involved in a fatal car crash, and that's a situation which affects everybody, really. There can be a lot of innocent bystanders, and I mean, to me, driving is a privilege, and it should be 0, really. And other states do have a 0 limit around that. And that's just me, to err on the side of caution around this, as opposed to open it up, see what happens, have some people get harmed, and then back down on it.
Thank you. Last question before lunch. It says, youth consistently report that THC has a calming effect and helps them to focus. Can you say what this is about?
Yes, I hear that as well. So we know that 30 to 50% of teenagers in substance treatment have co-occurring ADHD. And many of them will say, yes, it helps me focus. Doc, this is my medicine for ADHD. Why would you want me to not take this? And so what to say about this? I think I mentioned already how THC marijuana produces this, impairs divided attention. So in some ways it can help people be like super high focused on one thing at the expense of other things. I think also it can help people, just this is anecdotally, be a little less fidgety if they're kind of hyper. So the problem is basically the hippocampus. Remember all those little pink dots in the hippocampus, which is really important for learning and memory. And so we know that people who are using marijuana are impaired in terms of their memory. And in some cases, I showed you the subacute effects for up to a month. And in some cases, if it's adolescent exposure, it could be permanent effects. So there's much better ways, behavioral as well as pharmacological, to help people pay attention, focus. I think another thing to say about the calming effect and anxiety is there's a nasty cycle that happens. So people have anxiety and they will avoid what's making them anxious, and then they don't have the experience of overcoming and dealing with that anxiety, which then makes them more anxious the next time they might be faced with that anxiety-provoking event. And see what I'm getting at? It's really a positive feedback loop that's very dangerous. So when people are self-medicating this anxiety and this stress, whether it's PTSD in veterans or in kids or whatever it is, this is ultimately not a positive thing. It's going to lead to increased anxiety, at least the data that we have for that. One other thing to say about that, sorry Anna, pure THC has been shown to be anxiogenic. So pure THC causes more anxiety right away. So that's why we're seeing more anxiety attacks in our emergency departments with these high potency products and these edibles. And so also acutely there can be risk for increased anxiety.
Thank you. Thank you for everything that you've shared with us this morning and what you're going to share this afternoon. I also want to thank all of you as participants and an audience this morning for engaging in this material and submitting questions and dialoguing with each other. I think that's a really important part of us making this information real and bringing it home, so thank you for doing that.